Welcome to our sonography lecture on spleen pathology, part 5 of 7, focal pathology for the sonographer. This lecture will cover infections, abscesses, infarctions, trauma, and cysts. Let's go ahead and begin with infections. So the spleen is part of the reticuloendothelial system, which is basically your defense against all the crud and bugs that you can get sick with. And so it is kind of rare for the spleen to really become infected because its whole job is to fight off infections. But it does happen. So the ways that the reticuloendothelial system can become infected are through subacute bacterial endocarditis. So that's vegetation, infection of the heart muscles. Quite often actually it comes off of the valves of the heart. Septicemia is basically infection of the blood. Decreased immunological state, so that's anybody who's immunocompromised, AIDS patients, transplant patients, people going under chemotherapy, and then people who are abusing drugs. On ultrasound, if you haven't figured it out by now, it's splenomegaly. That's going to be your most prominent feature in a spleen that is being affected by an infection. And then those who are immunocompromised are likely to develop nodules that kind of go along with the immunocompromised reason that they're exhibiting. And I'll explain that a little bit more in the pictures here. So this is our first patient who has candidiasis. We talked about this back with the hepatic pathologies, that a patient can have a fungal infection that comes up as candidiasis. So you can have hepatic candidiasis, you can have splenic candidiasis, and it actually presents very similarly in the same way with that wheel in the wheel or target pattern. Mycobacterial infections can also pop up in the spleen. The one on the left is from a patient who had dental work, and oddly enough, dental work is actually a concern for heart patients. They're worried that little bacterias, while their teeth are getting cleaned or while they're getting their teeth worked on, enter straight into the blood circulatory system, go to the heart. Once they're in the heart, they start to create vegetation on the heart valves. Those little vegetation pieces break off, and then they go to other parts of the body, like the spleen. So this is where those endocarditis infections can come back around and affect the spleen. The one on the right then is a patient who has tuberculosis, and this one is presenting with more of a cystic area representing the infection within the spleen. This patient has AIDS. Again, we can see some small focal hypoechoic lesions and splenomegaly that goes along with it. Let's look a little bit closer then at splenic abscesses. So we know that abscesses are the body's way of trying to block off an infection. So usually there's a bacterial infection. That bacteria starts to produce pus. The body doesn't want that to get around to the rest of the body, so it starts to wall it off, and what we result then in is an abscess. So an abscess is a collection of pus that's built up in the tissue of the body. Now again, this is pretty uncommon for this to happen in the spleen, because the spleen is like ground zero for the creation of phagocytes and white blood cells and things that should be getting rid of the pus. And so these are pretty rare in the splenic realm, but they can still happen. As with abscesses anywhere else in the body, the patient is going to have very classic infectious symptoms, including fever. Because our discussion revolves around this possibly being in the spleen, they are going to present with left upper quadrant tenderness. They might have some other abdominal pain, some referred pain through their left shoulder and along the left side, and of course splenomegaly. On ultrasound then, what we're going to see is very thick or kind of shaggy walls on the lesion. And then after that, it actually has really varying appearances. We can have anywhere from an anechoic appearance, kind of like we saw with the tuberculosis. We might have poor definition to the lesion, or we can have increased to decreased transmission depending on what is in it. So if the abscess is really filled with pus, we might see some low-level echoes in there. We learned in past presentations that gas appears more as like echogenic foci with that dirty shadowing or ring down artifact behind it. So they really have a lot of varying appearances that they can present as. So here's an example of an abscess in the spleen. This one is more of a low-level echo, so it looks a little bit more solid, but this is still more like the pus, thick pus building up in the area. We can see kind of those ragged walls that we're talking about, and if there were to be gas in there, we would see echogenic foci or linear lines rising towards the top of the lesion. Here are some more examples of splenic abscess. These ones are a little bit more on the anechoic side, but they do have some debris within. Moving on then to splenic infarct. Splenic infarction is a condition in which blood flow supply to the spleen is compromised, leading to partial or complete infarction. So we've talked about infarcts in a couple different ways. We've talked about how in sickle cell anemia, those red blood cells kind of get stuck in the smaller capillaries, causing an obstruction of blood flow. When there's an obstruction of oxygenated blood to an organ, it's going to start to die. There's going to be parts of it that die off. We also talked about it with polycythemia vera. The blood is super thick, blood can't get into the capillaries to deliver the oxygen. So anytime there is a block of oxygen getting to all or portion of an organ, it's going to die off or infarct. Most common reason for a splenic infarct is emboli from heart thrombus. So we talked about how those mycobacterium infections from the heart can go into the spleen and cause abscesses. Kind of the same idea. If there is a clot or a thrombus building up within one of the ventricles, or specifically the left ventricle of the heart, that can break off, travels through, heads up to the spleen, and blocks off the small capillaries, causing an infarction. We can also get emboli from other areas that can break off and head to the spleen. And as we mentioned before, sickle cell anemia can also cause some blockages, causing an infarct. On ultrasound, it really depends on the timing of the infarct. Once the tissue starts to die off, the vessels become very weak and it can start to hemorrhage. And so if there is a hemorrhage, that hemorrhage is going to change appearance based on the age of the blood. And we've talked about this before. New blood is usually anechoic. If you think about how it looks in your vessels, it's black. Newer blood, when it's outside of the vessels, is also going to be black or anechoic. As the body starts to try to clot that bleed off, you're going to start to see more fibrinogen in the area, and we're going to start to see some more isoechoic, some more hyperechoic material building up in the bleeding area. Once a bleed becomes very established and starts to be absorbed again by the body, it's going to start to liquefy again, and so we start to see some more complex areas in the area of the hemorrhage. So again, infarcts start typically with a little bit of a hemorrhage. Depending on the age of the hemorrhage is what you're going to see. Once the hemorrhage is gone, the body gets reabsorbed everything. What we then see in the organ that is infarcted, the area is typically going to be a little bit more echogenic, and it's going to have a wedge shape to it. So the spleen in this instance is actually very echogenic, making the infarct a little bit more hypoechoic in this image, but I do want to point out the most important thing that you remember about splenic infarct is that it shows up as a wedge-shaped lesion in the spleen. So we can see here we have the base of the wedge towards the periphery of the spleen, where the apex or the point of the wedge is more towards the central portion of the spleen. So this is a very classic appearance of an infarct in the spleen. Moving on then to splenic trauma. Splenic trauma typically happens because of blunt trauma. And anytime there's blunt trauma to the abdomen, it can be an emergency. We're really worried about the spleen being injured, bleeding, hemorrhaging on itself, possibly rupturing, and secondarily, we're also worried about the liver having a laceration on it, having some sort of hematoma within it. Those two organs are very, very vascular, and they're very susceptible to blunt trauma to the abdomen. So when a patient comes in with blunt trauma to the ER, usually this is going to be done bedside by the ER doctor. They're going to perform a quick scan, and they're going to look around for fluid in all four quadrants. They're going to double check for fluid in Morrison's pouch, looking in the subdiaphragmatic areas for fluid, and then they're going to do a good look through the spleen and through the liver, looking for any sort of hemorrhage that might be visible. So just looking at the splenic trauma side of things, the spleen is the most commonly injured organ as a result of blunt abdominal trauma. So a person falls off a ladder, gets in a fight, gets in a car accident, kicked by a horse. We really want to make sure that we are evaluating the spleen, looking for any signs of hemorrhage or lacerations or any sort of tears. It's not uncommon for the ribs to puncture into the spleen, so we want to make sure if there's any broken ribs that we're again looking for any sort of bleeds in the area. Patients who have a history of trauma and splenic damage are going to present with left upper quadrant pain, left shoulder pain, left flank pain, and they might have some dizziness, especially if there is a severe internal bleed occurring. The dizziness is secondary to hypotension, which occurs because there's not enough blood still within the circulatory system, which leads us to believe that there is an internal hemorrhage. Lab work then is also going to show a decreased hematocrit. Again, that's how many red blood cells are within the volume of our blood. Typically, when there is an active bleed within the body, hematocrit decreases. When evaluating the spleen for trauma, then, we're going to look for splenomegaly. If the capsule of the spleen is still intact, but there's internal bleeding in the spleen, that's going to cause the spleen to enlarge greatly. If there are tears or lacerations in the spleen may take on more of a ragged appearance. Again, the blood that we see is going to be relative to the age of the blood, so we can have anywhere from anechoic to isoechoic to hyperechoic to complex presentations. We might see the hematoma within the tissue of the spleen, or we might see it along the capsule, which is considered a subcapsular bleed. If the spleen ruptures, then we would expect to see blood or free fluid within the abdomen. So here's an example of a splenic hematoma. These are bleeds that are actually within the tissue of the spleen. So you can see that here and here. It actually looks like there might be a little bit of a subcapsular hematoma starting up here. This one is a splenic laceration, so we've got kind of ragged appearance. We're seeing multiple poolings of blood within the capsule. Here is another large hematoma appearing outside of the splenic capsule, so there's most likely some sort of rupture within the spleen. Lastly, then, we have splenic cysts. Now, the spleen is just as susceptible to any other organ in the body to develop cysts. The cysts are typically just fluid-filled sacs within the spleen. We have two avenues in which cysts can appear on the spleen. First one being non-parasitic. Those are going to be secondary to trauma, infection, or infarction of the spleen. Typically, these are going to be areas that had some sort of hemorrhage. The hemorrhage has become cystic, and now we can see it with ultrasound. The second avenue, then, is parasitic cysts. The echinococcal cyst, or the Hydatid cyst, is the only parasitic infection that we typically see in the spleen, and it takes on a very similar appearance as to what we see in the liver. If you recall back to Hydatid cysts in the liver, that one has three particular presentations that it typically has: daughter cyst, honeycomb, or water lily sign. Here is an example then of a cyst in the spleen. Typically they are going to be anechoic, thin-walled, with through transmission. Here is another cyst seen in the spleen, very tiny. And that brings us to the end of part 5. Next up, we're going to talk about part 6, benign neoplasms of the spleen.